Opportunity to speak to a very well-attended session and also to be the warm-up act for the next speaker. So you will hear a little bit more about the Chest Wall Injury Society for those that don't know in the Chest Wall Working Group meeting following this. But what I want to do is to present to you some work that we've been doing both within the Chest Wall Injury Society but also as an institution looking at the definitions and patterns of injury. I'm going to talk very briefly about the fracture compendium published by the Orthopedic Trauma Association and the AO Foundation in January last year, the work of CWIS in taxonomy, and also some of our own work, as I said. I think it's really important to recognize that until recently there's been no agreed taxonomy for blunt chest wall trauma in the various different aspects that we see here. And it's really, really important for us to have consistent definitions so that we can communicate properly, so that we can ensure that we have good outcome data, and also for the interpretation of clinical trials. So in January last year, you can see the authors for the thoracic elements on the right side of the screen here. This was a publication of some nearly 200 pages covering every fracture of every bone that could be classified in the body. You can see here how the working group here looked at the posterior end different to the shaft of the rib and different to the costal cartilage, and I'll come back to this later. They also addressed the issue of the costotransverse and costovertebral joints and defined the terms of partial and complete costotransverse disruption. The AO nomenclature for all bones is very clear in terms of the definitions of simple, wedge, and multi-segmental fractures, and these were applied using numbers. So the whole point of the AO classification for all fractures is to assign a code for each individual fracture. Furthermore, they looked at the sternum as well, and you can see the codes here for the different types of sternal fracture according to the manubrium, the body, and the xiphoid process. With CWIS, we did a work which has been published online, but is not yet in the print copy, which was a multinational effort to try and derive a consensus at different rib fracture definitions. What we did was to perform a literature search of all possible rib fracture definitions. We chose a working group and conducted a Delphi survey using conventional methods. We created an email list of every first and lead author of all rib fracture surgery papers over a 12-year period and included various other experienced surgeons around the world. And we conducted 3 rounds of consensus and were able to achieve 113 responses from 18 different countries. In one slide, this is the results of the study, and I'm not going to try and go through it in such a way, but you can see, for example, in the second down on the left, you can see how multiple answers were revised with subsequent rounds of the consensus to enable us to come up with a proposed definition. In summary, we felt that the categories of displacement should be defined as undisplaced, offset, displaced. I will show examples of these in the next slide. Fracture lines and fragments should be described as simple, wedge, and complex in agreement with the AO nomenclature. Associated fractures should be described as a series where they have a summative pathologic effect. So here are examples of undisplaced, offset, and displaced fractures, and we felt that the cut point, and this is to be proven, and I'll come back to this later, is where an undisplaced fracture is where you have 90% of cortical contact, and offset is where you have between 0 and 10%, and displaced is where you have no contact between the cortices at all. And you can see here again examples of simple, wedge, and complex fractures. When it came to defining the anatomic location of the fractures, we described these as sectors, and the consensus exercise suggested that there should be 3 different anatomical sectors, anterior, lateral, and posterior. We should additionally have a costal cartilage sector, and that there should be we also discussed whether there should be a paravertebral sector, but we're not able to reach consensus on that, or you can see that there is a steer from a substantial majority of expert opinion. When it came to determining what the boundaries should be between the sectors, this was more difficult to determine methods. In summary, the auxiliary lines were felt to be the appropriate sector boundaries, But then when you try to determine how you assess the axillary lines, it gets very messy. And there are various different options which you can see in the paper itself. Flail is a difficult word, and I appreciate that the English language uses the word flail, and I appreciate also that there is a lot of disagreement about whether flail is a useful term, but it is in such common usage that we felt that we had to keep this in the proposed classification. But we felt that it was helpful to use the flail segment as a description of the radiology, whereas the flail chest is the appearance of paradoxical motion. In terms of the number of ribs, it was a fairly clear consensus towards the usual convention of 3 or more ribs fractured in 2 or more places. But when it came to asking the questions about how many ribs needed to be displaced to give a flail chest, we were unable to agree. And similarly, we were unsure about how to include those fractures in the paravertebral sector. When we came to fractures around the front of the chest with an anterior flail, we were able to agree a definition about an anterior flail, but when we started to include the sternum in that, it became, again, more difficult. So I just want to acknowledge the 113 participants, I'm sure that many I know are in this room, that enabled this project to proceed. When it comes to applying those definitions to data, it takes a fair amount of work. And I was lucky to have a young student sit with me and go through 539 scans, coding 3,944 individual fractures according to all the different possible consensus criteria. It took him a year. And we've matched these to outcome data, and effectively this is work that is ongoing. I'm not going to present the data, but in conclusion we found that most of the consensus proposed definitions demonstrated clinical relevance, but there are some that require extra work. And through the potential collaborative work of multi-institutional data collection, just as for cancer staging, we hope that we will be able to drive forward the taxonomy of rib fractures in this way. When it comes to institutional methods, I guess we all have our different ways of recording the forms, and what you can do is to apply these definitions to your record charts and then allow your colleagues to communicate. We can see here the costal cartilage, the costal margin, which we'll talk about shortly, and here is, in simple form, an injury that we can use. And we can use this for planning purposes in order to determine whether we think a patient should be considered for surgical stabilization of the rib fractures. So what I want the resident to tell me is I want them to apologize for disturbing me, but I would like them to give me a lot of information. I would like them to tell me that there are 2 fracture series described as this, and that there is overlap creating a 4-segment flail segment, and of course whether there is a proposed management plan in place. So in the middle of the night I can then take this diagram in my head and I can consider exactly what is the taxonomy of the injury. And you can see here how that works in terms of me bringing up a picture, and I can then decide whether I need to have a look at the images myself, whether I need to come in, whether we need to prepare the patient for surgery. When it comes to the costal margin, it's more difficult again, and we recognize that there are the 3 different muscle planes attached to the costal margin, and the costal margin rupture may include injuries to these muscle planes. Again, taxonomy is incredibly inconsistent. The case reports is the formation in the literature frequently described as rare, bizarre, unusual, unique. You see multiple different terms for very similar injuries. And so when we started to recognize these injuries in our practice, what we wanted to do was to try and create, again, logical taxonomy. And what we've done in our own work is to apply the concept of segmental sequential analysis as used for pediatric cardiac defects to analysis of the costal margin, the diaphragm, and the intercostals. And thereby you are able to create a taxonomy that is logical and makes sense. When you have this, you can then apply appropriate management to the patients. So here is an example with a high velocity injury. You can see the aortic stent with trans-diaphragmatic intercostal hernia. And you can see how we repair this using a double layer mesh technique, as we've published recently in the European Journal. And equally, you can have at the other end of the scale a patient with a symptomatic costal margin rupture who may respond very nicely to plate and screw fixation, which again, I admit is relatively contentious, but it works. So I think it's extremely important to analyze these the costal margin injuries in a logical fashion, and then that allows an appropriate management to be created. So whether this is correct or not is difficult to say, but when you have a literature base that is purely case reports, it's going to require data collection and potentially collaborative efforts to work out what we feel should be the correct type of management. So in summary, we've talked a little bit about the AO and OTA fracture compendium, and further on from that, the work of the Chest Wall Injury Society in creating logical and agreed taxonomy, and also some of our own work looking at assessment of injury and costal margin injuries. It's extremely important, just as for lung cancer staging, that we apply standard taxonomy in our reports, in our research and communication between members, and therefore we can then audit our outcomes most effectively. I'd just like to acknowledge my research fellows over the years that have worked in the Sheffield multiple rib fracture study, coordinators, and of course my esteemed colleagues without whom I could not be here. Thank you.